Most healthcare grade disinfectants are really excellent at killing many organisms if they're used according to manufacturer's directions, which is great, but they don't kill all infections or all pathogens in the environment.
Public health. It's on everyone's mind these days, from hand washing to emerging pathogens. Welcome to Transmission Control, an infection prevention podcast focused on your appetite for trailblazing thought, discussion, and innovations that will help you make informed decisions. Each episode, we speak with public health experts and safety champions from across the globe as they share their experiences, passion, and opinions. From investigative journalism to medical publications, we tackle real-world barriers to halting the spread of disease. Whether you are tuning in for education, inspiration, or to hear the stories that need to be told, thank you for joining us. And now, get ready to blast off with your weekly injection of insight on transmission control.
This week on Transmission Control, we speak with Marc-Oliver Wright, Clinical Science Liaison for the Central Region at PDI Healthcare. And we found Marc online on LinkedIn, saw a podcast and some other information from a blog that they have over at PDI. And it was really on the heels of a conversation that, Larry, you and I had with Daryl Hicks about environmental services. But today, we really wanted to talk about that interplay between the dynamics of human factors versus technology and even systems that are in place for environmental cleaning, and how to know where the opportunities for improvement are, and also talk through the three technologies for disinfection and how they work together and in the right settings. So I'm excited for everyone to hear this discussion with Marc, because he really does a very nice job of painting the picture for us as we talk through some of these concepts.
Yes, and I'm hoping to kind of apply the principles of environmental services to some concepts that maybe the audience wouldn't be so familiar with or think would be applicable to environmental services and to human factors. For example, risk assessments, and I'm hoping we can talk about that, and in particular talk a little bit about human factors as they apply to endoscope reprocessing, and whether the transmission of an organism by an endoscope is a result of the design of the endoscope. Is it a result of a human factor interface problem? Is it a little of both? Is it one or the other? And I'm looking forward to talking about that and hearing what Marc has to say.
All right. Well, we're going to be right back in just a couple of minutes for an interesting and engaging conversation with Marc-Oliver Wright, Clinical Science Liaison for the Central Region at PDI Healthcare. I'm Justin Poulin.
And I'm Dr. Lawrence Muscarella.
From 17 Studios, let's get into it. This is Transmission Control.
Joining us now is Marc-Oliver Wright, Clinical Science Liaison for the Central Region at PDI Healthcare. And Marc, I'm just going to say that we found you on LinkedIn. Some pretty interesting conversations going on there. And as we sort of got to know each other, I found out that you also do a podcast, which, by the way, when you reach out to a guest is always a great thing to hear, because you just know it's going to be a good interview. So I wanted to thank you so much for coming on the show today.
Oh, thanks, Justin. Thanks so much for inviting me to come with you. You know, I've been a huge fan of podcasts for years now. And, you know, a couple of years ago, I was invited to join an APIC podcast. And APIC is our professional organization for infection prevention. And they asked me to come on as a guest. And it was, you know, frankly, a dream come true. When I left the acute care setting of infection prevention and joined PDI a few months later, you know, I did so right before everything really upended and changed with the pandemic. And then starting last year, I was asked to host a podcast at PDI that was aimed at our colleagues in the field of infection prevention. So it's been so much fun, you know, and after all, Mom always said I had a face for radio.
Yeah, I think that makes two of us. Otherwise, this would be a video project. But I will say, why don't you tell everybody about the podcast a little bit more in depth with PDI?
Sure. So this is a PDI podcast, and we started this during the height of the pandemic in the second and third quarter of 2020. And what we were doing is we were reaching out to colleagues that were available in the field of infection prevention, to provide some insight. So one of my first guests was Kath Murphy, and she is a past president of APIC, but more importantly, she had just finished a winter season during our summer by living in her home country of Australia. So she provided some really interesting insight into from an international perspective in terms of how they were handling the pandemic, how they were managing lockdowns and the challenges that they were facing. And even more importantly, and this was about the same time this information was coming out, how seasonal influenza was basically non-existent during their winter months there. And it was kind of an interesting conversation because it was something that they had just started realizing that in the Southern Hemisphere during our summer of 2020, that the pandemic measures that were being taken also may have had a contributing effect in reducing transmission of influenza. So that was just one of our first guests. But we've had an opportunity to have a number of conversations with people both within the U.S. and outside the U.S. with regards to their experience and their expertise during this really challenging time that we've all been facing.
Well, the value of podcasting, as you identified, is really strong. And I think it not only was already taking off before the pandemic, but for all of us self-learners out there, what a great way to be able to continue that learning. And I think education is just beginning to take a totally new form around the globe. And it's been expedited, but it was already underway. And I also like the use of social media to create increased awareness and discussion, and so I think you've really done a nice job of getting involved in all of those areas. And we reached out to you to really talk about environmental cleaning and disinfection. And one of the things that we wanted to talk about is this interplay between human factors and technology and all of those dynamics. And so I thought we might start by just summarizing some of the human factors in environmental cleaning and disinfection. And specifically, one of the things that you educated me about was the SEEPS model.
Yeah. So the SEEPS model, or Systems Engineering Initiative for Patient Safety, this is a concept that was initially developed by Dr. Pascal Carrion at the University of Wisconsin. And it's really a subset of human factors engineering that focuses the principles of human factors specifically in the healthcare setting. And it's really rooted in this idea that outcomes are derived from processes, and that processes are derived from work systems, and that these work systems are comprised of various interrelated elements. So let's take a look at those elements, right? They are really the focus. They include things like the organization, the physical environment, the tools and technology that you mentioned, and the tasks and people who actually perform those tasks. And when optimized, your work system is really likely to produce the desired processes and outcomes that you want. When they're not, or one or more element is just out of sync, your processes and then ultimately your outcomes are not going to reach their full potential. And in some cases, it's going to fail outright.
Interesting. So I have a question for you, Mark. And in terms of the whole issue of human factors, I've studied a bit in terms of contamination of endoscopes, something that's been a really hot topic through the years and particularly recently. When the FDA started looking at endoscopes and started specifically duodenoscopes used in an upper GI procedure called ERCP, and started finding a higher than expected contamination rate of these duodenoscopes. They were contaminated more with high concern organisms than we might have thought after reprocessing. So the FDA circa 2015 said to the endoscope manufacturers, let's do some post-market surveillance studies. And there were two types of studies, and we can focus on one of them. Well, the first one was performance. So why are these endoscopes contaminated? And first, to what degree are they contaminated? And as I said, the FDA found them to be contaminated with more bacteria than expected. So the second part of the study, the first being to measure the contamination levels, the second part was a human factors study. So I think maybe you can educate me and the audience on the application of your understanding of human factors specifically to endoscope reprocessing. So for example, we have tools which might be the use of the detergent The task would be endoscope reprocessing, the people, the endoscope reprocessing techs, and the organization and the culture behind that as to how much emphasis we put on that. So without me saying much more, can you talk a little bit to the extent that you're knowledgeable about maybe applying some of these human factors in addition to environmental surfaces? Can we bring it into the world of endoscopy a bit?
Yeah, absolutely. I think the first thing to really appreciate and to recognize is that an endoscope on the outside looks like a glorified black garden hose. Doesn't look like it's particularly cumbersome or challenging to use. But on the inside, there are these intricate spaces. And so when you look at what an endoscope reprocessing technician does, there is the mechanical, physical removal of organic material before you go down the path of reprocessing and performing high-level disinfection of these instruments. And I mention that because they can become extremely complicated from a medical equipment standpoint. So there's a training element that's involved that gets the technician familiar with the device. And then you add the second point to this is that scopes are manufactured by different companies and that each one is slightly different. And, what kind of scope an organization use might be uniform, and every physician uses the same endoscope model. But more commonly, what you're going to come across is you're going to come across provider or physician preference or variations from one department to another, such that you might have different scopes with different intricate pieces from one scenario to another. So not only does the technician need to know the fundamentals of what they're doing, which goes to their own individual competency and awareness, but they have to know across multiple manufactured models. And that's assuming that these devices themselves are designed in such a way to be conducive to the physical removing of organic material. Because if you don't remove that organic material, you can put a scope in an endoscope reprocessor with a high level of disinfectant and still have an abundant number of organisms come up positive afterwards.
So this focuses very well on the human factors standpoint, because the question then becomes, if a reprocessed endoscope is transmitting infections and the FDA is finding the contamination rate to be higher than we would expect with these concerning bacteria, is the problem the design of the endoscope? Is the problem a human factor one? For example, maybe the scope can be cleaned and cleaned thoroughly if staff can understand the instructions for use. But from a human factor standpoint, you could give them a recipe, a IFU, an instruction for use, and tell them what to do. And if they do it properly, we have no problem. But what if they can't interpret those IFUs? What if they can't understand them? That's a human factors issue, yes?
Absolutely. So if you look at the CRE outbreaks that were in the Los Angeles area in the early 2010s, and it was with a particular model that had an elevator channel that was closed off on one end. The manufacturer that designed this particular scope, if I'm recalling correctly, did so because it was, from an operator's standpoint, the clinician's standpoint, an optimal utilization of the device.
Yes, that's exactly right, Mark. The intent of the designers was to seal the elevator channel to obviate the need, that is, to completely eliminate the need to reprocess the channel.
From a functional cleaning and high-level disinfection standpoint, it basically created a dead end where...
Or a conflict.
Yeah, a conflict. So that it basically made the technician's job, I don't want to say impossible because that's not, quite accurate, but made it much more difficult. And it was something that they had never seen before. And oftentimes healthcare organizations make purchasing decisions around diagnostic or medical equipment based off of provider preference, which is understandable because the person using it needs to be comfortable and confident that it's going to do the job that they want. But they don't necessarily fully evaluate the whole process, right? So it's not just about how well will this scope help me diagnose this patient's condition. It's also, how am I going to reprocess this, and how does this differ from my existing or current practice? And then how do I navigate those challenges? So is it the tool or is it the human factors? And my answer to that is sometimes it's actually both.
And it's that interface then, that tension between that tool, the device, the endoscope that has been designed specifically to facilitate the procedure and help the patient. That's a little bit in conflict with this human factors issue, where if we can blend and dovetail them well, we have no issue. But sometimes there can be some conflict there and kind of some pushback. So I think here's an example of the human factor issue really coming into play into the real world, where we can have endoscopes transmitting superbugs from one patient to the other based solely on, for example, a human factor issue where maybe they couldn't understand the IFUs, they couldn't follow them, there were too many steps. And so all of this, we can talk about maybe optimizing the IFUs and optimizing the instructions for any type of device so that the end user who is interfacing the tool or the cleaning tech who's interfacing the tool can really understand, work well with the device and assure that no debris remains on that.
Absolutely. I mean, I think it's important to start out with a premise whenever you're trying to troubleshoot these issues. And that premise is that no psychologically healthy individual wakes up in the morning and says, I can't wait to be the worst at my job today. You know, in my experience, this is particularly true in healthcare, regardless of the role. You know, no one wakes up wanting to endanger or hurt patients. You know, success has many fathers. Failure is rarely an orphan. The persons that are performing the task may be out of sync. Maybe they're not aware of the IFU. Maybe they don't understand it, but it almost certainly isn't the only element in that work system that is out of sync.
So, Mark, we just did an interview with a guest, Daryl Hicks, and we talked a lot about environmental services as a department, the resources, et cetera. And I know we're going to talk a lot about that as we continue the conversation. But, you know, Larry really brought something up that I think will set the table well, which is there was a lot of, we're trying to figure out whose responsibility this gap belongs with, right? And yes, that usually is. There's a little bit of responsibility in lots of different areas, but how would an infection prevention professional determine if there's a situation where it's a human issue or it's a systems issue? And I'll even go further, since it's, you know, coming off the heels of the conversation about a device or device design, like teasing all of that out, especially because we know there's a shortage already in the industry with IP professionals with an increasing demand. There's going to be lots of new blood coming into the field. So they may not be as experienced at teasing that out. What are some thoughts that you have around kind of understanding the dynamics and where maybe the opportunities for improvement lie?
Yeah, well, that's a great question. So to me, the default mindset for anyone, especially in infection preventionist, pursuing this kind of question, is this an individual issue or a human factors issue? The default mindset really should be the improv approach. Yes, and in other words, yes, maybe the individual or individuals are not performing as desired or expected, and certainly that needs to be addressed, but not before we try to seek out and identify other contributing causes. You know, when you look at something like environmental services, I think one of the challenges is, you know, much bigger than the environmental services department. It's looking at organization or the culture at the organization itself. You know, does the organization recognize environmental services or endoscope reprocessing technicians as inherent and vital parts of that healthcare delivery team that are on par with the same people who provide direct hands-on care to patients? If that culture isn't there, that doesn't embrace that, you know, sort of mindset, then that's a you know, a good starting point. Does your staffing model for these tasks reflect the needs and complexity of, and frankly, the volume of the facility, right? Do the employees have a clear understanding of not only what they need to do, but why what they're doing is so critical to ensuring a safe environment for patients? I've had the privilege of working with endoscope reprocessing technicians and environmental services professionals for the better part of the last 2 decades. And I can tell you there's nothing more worth investing time in than making sure that the culture is right, that people understand the critical role that they play. Because once they do, they take their responsibilities seriously and more seriously than they may have when they first, you know, signed on for that job. Not a lot of people, you know, necessarily start out and say, I want to be reprocessing endoscopes. They sometimes sort of, for lack of a better way to put it, fall into that role. And you don't want them to approach their environment, their tasks with a laissez-faire attitude. They are the reason that we're able to provide safe and effective care to patients. And I've worked in some very high reliability organizations where that culture was really celebrated, that environmental service workers, for example, were viewed as very much part of the healthcare delivery team, such that the nurse would introduce the environmental service worker when they first came into the room for the first time and said, "This is John. He's going to be your environmental service worker while you're on our floor." And having that sort of, approach to empowerment, because also not only is it focusing their efforts, but they become an ally. They become your eyes and ears. And so they see something that's wrong and they feel that they're really part of that healthcare delivery team. Then they'll go to somebody and say, "Hey, I saw this. Is this okay?" They'll ask the important questions that might otherwise get missed.
Yeah, if you make them feel like the role is not important, then they will approach the role like it's not important. And the truth is, it is. And you just touched on something that Daryl Hicks said about really how to elevate that. He really went so far as to say that, environmental services team is really part of the customer care team and this whole new focus that healthcare has around the customer experience, right? And so you're like really in sync with a lot of that conversation. But I think also people don't necessarily even understand what environmental services is doing. Sometimes people think, they just go in with a mop and, they a washcloth and, and it's just like, it couldn't be farther from the truth. And there's actually a lot of science and technology behind it. And one of the reasons we reached out to you to come on was to really introduce technologies for disinfection. And when you and I talked, you said there's really three. There's some traditional ones, there's some supplemental disinfection, but then this concept that I didn't really understand that I'm really hoping you'll take some time on today, which was continuously active disinfection. And I want to talk about, as you describe them, maybe introduce them, but also talk about some applications and maybe how they fit together in environmental cleaning.
Absolutely. Absolutely. I couldn't agree with you more. So, traditionally, predominantly, and, for many, many, many decades, healthcare EVS programs were focused on disinfectant solutions or chemical-based disinfectants to both clean and disinfect surfaces, which is great. They can come in different formulations, like there's a wipe or there's a spray or a liquid formulation. But those are the three that are most common. The first thing to think about is that most healthcare grade disinfectants are really excellent at killing many organisms if they're used according to manufacturer's directions, which is great, but they don't kill all infections or all pathogens in the environment. So, for example, there's a class of disinfectants that are probably most commonly used in healthcare, and they're called quaternary ammonium agents, and they kill just about everything, but they don't usually kill a common infection seen in hospitals called C. difficile. And for that, you actually need a sporicidal agent because the microorganism itself is different than a regular Staph aureus species or a strep species. So then you're talking about using two different kinds of chemicals. And using two different kinds of chemicals kind of adds a layer of complexity. So if you go back to the human factors element and say, okay, I'm not going to use one thing all the time. I'm going to use this thing most of the time, but sometimes I have to use that. The challenge with that is that complexity is conducive to error. You have to communicate the needs to the person performing the task in a very high volume, high stress, high throughput environment. And the other issue has to do with the physical environment. When was the last time you actually really looked at an inpatient room in a hospital? These things they're huge and they're filled with all these nooks and crevices and complicated equipment. And I saw an article a number of years ago that showed that up to 50% of hospital room surfaces get missed when the patient's discharged. And frankly, it doesn't matter what chemical agent you're using. If it doesn't actually hit the surface where the organisms are, they can actually live on that surface for a couple weeks or months. And if they're sitting there, they're just waiting to infect that next patient. So that's where we get into those newer technologies. And so the newer technology, one of them is, as you mentioned, supplemental disinfection technologies. And these things include things like vaporized hydrogen peroxide or hydrogen peroxide mist, that sort of emits a gas in a room, or ultraviolet light or UV light emitting machines, sometimes called robots, that actually emit UVC wavelength light throughout a room to kill organisms that might get missed. There have been studies that have reported that using these tools kill the organisms on surfaces that might have been missed, and therefore decrease that risk of infection for the next patient. The problem is with this category of supplemental disinfection is they come at a cost. And the first cost is the capital equipment purchase itself, but they also take time. You have to actually physically remove soiling. You can't use a supplemental disinfection strategy as a replacement for traditional cleaning and disinfection. You have to clean up the physical environment first and then use the supplemental disinfection, which is great. The other thing is they take time. And when you're talking about organizations that are functioning at a lower bed capacity, let's say that they've got a 60% bed occupancy rate, that may not be a really big deal. But if you're talking about a higher occupancy rate, or for example, say during a pandemic, for example, you are in a hurry to get the job done. And lastly, not all areas are really conducive to using this technology. There's some concerns that while they may be good for rooms where you can close off the room, large open spaces like a clinic or an ED waiting area where manual cleaning might be limited to no more than once a shift or once a day. That's where we kind of get into the continuous active disinfectants. And so this is actually a category that goes back to chemicals, but instead of a surface being disinfected and then immediately susceptible to recontamination, it actually leaves behind a shield of protection that actually keeps killing common or epidemiologically important organisms like MRSA. And so this is a new paradigm in cleaning and disinfection. Perhaps an example is a good point here. So let's say you're going to your family medicine clinic, and the first patient walks in and happens to be colonized with MRSA. That's not why they're there. They're there for a routine checkup, but they're colonized with MRSA, and they check in, they sit down in the waiting area, and they set their coffee down on the nearby table. A couple minutes later, they get up and go up to be triaged, and then patient 2 sits down. But in the interim, those MRSA organisms from patient 1 have been killed if there's a continuous active disinfectant in place. And that's really the potential here. That's where the paradigm shift is. And what's interesting to me is that every time you introduce new technology, particularly when we're talking about the environment, it's not necessarily a replacement or improvement. Sometimes it's actually a paradigm shift. And I would say with both supplemental disinfection and continuous active disinfection, we're really talking about a paradigm shift. And what I mean by that is that it really upends your work system to a certain extent. So for example, you might think, well, I could use this continuous active disinfectant on shared medical equipment, like a blood pressure cuff, and then I only have to clean it once a day. Well, no, that's not really the answer. You don't want people using non-dedicated patient care equipment on multiple patients throughout the day without disinfecting it in between use.
Mark, that's so true because, working as a nurse myself, we always had shared blood pressure cuffs. That's just what, we used them. And I do not recall, and it's been a while. We've come a long way. I haven't been working actively, with direct patient care for 10 years. But I can tell you, I don't ever recall anybody telling me to clean it off or having any training around that. We just took it from one room to the next room to the next room. And, here I am, somebody who has actually done patient care and worked in these environments. And I'm telling you that, just very honestly. So I do remember there being disposable blood pressure cuffs, but I actually I think I only used those when I did home health. I don't recall using them in the inpatient setting. And I worked as a CNA for many years from 99 onward as well.
Absolutely. I've had the same experience. I can tell you at a previous organization, I was looking into a handful of cardiac surgery infections, and you go into the operating theater and you observe the case and you make a list of questions to ask. And one of the questions I remember asking is around the bypass machine, this very relatively large, very expensive piece of equipment that's off to one side that doesn't necessarily come in quite direct contact with the patient because it's really the disposable equipment that comes in contact with the patient. But I remember the case was done, and I went to the technician And I said, how do you clean this? And he says, oh, I don't. That's environmental services cleans that during their room turnover. And then I went to the environmental service person who was out in the hallway, and I asked the same question, how do you clean this? And he said, oh, I don't. That's too complicated of a piece of equipment. The technician does it. And that's right about the time that your heart goes into your throat and goes, this is not getting disinfected like it's supposed to. And a lot of organizations have gone through the very time-consuming and albeit tedious task of laying out their most common pieces of equipment and whose responsibility it is to clean and disinfect them and when. Now, that, of course, being said, you could write this down. You could have a 5-page document. If nobody reads it, nobody understands it, and it doesn't get communicated, then it's not really worth the paper that it's printed on. But having that evaluation of whose responsibility is this and when is a good first step. Because, when I talked to both of those individuals, they were both quite confident in their assessment of whose responsibility it was and how often it was getting done. And they were both, unfortunately, wrong because they weren't necessarily communicating about it.
Well, Mark, a real key to that, there's an element in design control where we talk about risk management and risk assessment. And in risk assessment, we kind of come up with two questions. One is, what is the probability of contamination? And what is the severity of the injury if the surface were contaminated? So I think that's part and parcel to exactly what you're talking about. I think if you do an analysis and you find out that particular piece of cardiac equipment is very rarely contaminated, and if it were contaminated, the likelihood of an infection was so low, you could argue then that certainly that has to be decontaminated, but it might be decontaminated a different way than if in your analysis you found that a contaminated surface had a high likelihood of exposing an immunosuppressed patient with a high load of a deadly bacteria. Can you discuss a little bit of that in terms of like a hazard analysis, a risk analysis that we use in design control, and how that eloquently dovetails and relates also, which I was surprised to know until I did some work in preparation of this podcast, it kind of dovetails and right into the whole environmental cleaning procedure analysis. Can you talk a little bit about that?
You're absolutely right. Going back to the example that I gave, was I nervous that this was a contributing cause to my cluster of surgical site infections? No. That being said, it sort of highlights the disconnect that can happen. So you're right. So it is really about risk of contamination and risk to the patient. The interesting thing is that a number of years ago, the CDC put something out called a list of high-touch objects that acute care facilities should be monitoring for their frequency of cleanliness inside of a traditional inpatient room. And they put out a list of about 16 different objects, and it included things like doorknobs, light switches,
right,
bed rails, all that good stuff. And that was very helpful because it in the sense that it got people thinking and talking about how do we monitor our effectiveness at cleaning the environment. The problem with that assumption, though, is that it's only those 16 objects you need to worry about. And so if you're not on that list, don't make the mistake assuming that you don't need to worry about it, because there is no evidence out there to suggest that a less frequently touched object is any less likely to be contaminated. Now, that being said, it may be less likely to serve as a vector to the healthcare worker hands to the next susceptible patient. But even if the risk is, say, half, I don't like those odds, because I can tell you in an inpatient room, there's a lot more than 16 objects that need to be cleaned.
Right.
So what we did with that is we actually, one, expanded that list, two, rotated it so that the individuals who were being monitored weren't as susceptible to the Hawthorne effect. Right. And then three, would have a double check, because, there's only so many infection preventionists in the facility, and there's only so many people that can, mark these areas or monitor these areas. So we decentralized that process, but then put a check and balance in there where a different person would come in periodically, unbeknownst to everyone else, mark some areas and monitor for cleanliness. And all of that goes to say that sometimes there's an assumption that the healthcare environment has to be sterile. First of all, that's unrealistic. Second of all, it's impossible to maintain. And third of all, it's not really necessary. Obviously,
the risk analysis says it isn't always necessary. That's right.
Absolutely. So that being said, when I look at, for example, and I keep going back to this, an emergency department waiting area, and you see you're a community hospital or you're a large academic medical facility, either way, your ED waiting area is very rarely empty. So it's very rarely empty, and it often has the people that are coming in before they're being triaged, if they're, not in a life-threatening state, sitting there. Then you could argue that the risk there is perhaps lower from a transmission standpoint, but the likelihood of contamination is exceedingly high because you have a high volume of people coming in. And then you also have a diminished capability to get in there and environmentally clean and disinfect the area on a regular basis, or at least nowhere near as much as you would like.
And that analysis tells you whether you need to implement a corrective action or mitigation, more so in order to remedy the problem. So in that risk assessment and in that risk analysis, when you do the severity of the outcome and you do the probability of the injury, you come up with some type of a number. And if that number is below a threshold, you really don't have to implement a mitigation. You're basically good to go. Keep surveillance, keep monitoring. But if it's above a threshold, then the equation, the formulation says you must implement a mitigation, do a reassessment, and then show that prior to your mitigation, you had a higher likelihood of injury, and after the mitigation's implementation, you had a lower risk of injury. That is a classic case of design control risk assessment. And in the environmental cleaning arena, it can go to the heart of, with limited resources, what needs to be cleaned, how often does it need to be cleaned, how does it need to be cleaned, as we need to conserve our resources and focus only on that which really needs our attention.
And I think it's important to focus both on process and outcome measures. We talk about healthcare-associated infections a lot, like they're happening nonstop. But the fact of the matter is that to more or less extent, they are relatively rare events. So just because you don't get a p-value of less than 0.05 doesn't mean that your intervention wasn't important. It doesn't mean that it didn't work. It doesn't mean that what you did is not connected to your outcomes. So establishing those endpoints and determining what is an acceptable measure of success is really something that needs to be done upstream and takes effort as well. I agree.
Yeah, good point.
So, Mark, last question here, and I'm going to kind of tie a lot of that together, at least I hope. And it's around those three technologies, and you kind of walked us through them and said, well, this one's good here, this one's good here. This one might complement this one. But then you also told a story. Well, not really a story. You described the emergency department waiting room as a setting, a challenging setting due to traffic at all hours throughout the day. And it's not like a room that turns over, and it's larger and there's more nooks and crannies. And so is there a world where you're taking a more layered approach with those three different technologies to be able to tackle some of these difficult environments successfully?
Absolutely, Justin. This is exactly what we mean by a layered approach. And what a layered approach is, that this is a philosophy that we try to use with our customers, and it speaks to that need for methodical approach to environmental cleaning and disinfection. And it starts with a recognition that hospitals need multiple layers of defense to ensure the highest level of cleanliness that we can accomplish, because no single approach can completely eliminate the environment of germs and pathogens. Like I said, creating a sterile environment is just, not particularly feasible. And the layered approach really consists of 5 steps. And the first is to establish and evaluate a standardized, evidence-based approach to their policies, protocols, and procedure, and see how those line up with what are the recommended best practices. And this includes things like who cleans what, how and how often, going to the model we were talking about just a moment ago. And then that next step needs to include an evaluation of what surface disinfectants, traditional or continuously active, are particularly warranted. Is this an area that has a lot of patients with C. diff? Maybe we should use a universal sporicidal agent in, for example, a GI setting. And then this is followed by determining the needs and optimal placement and utilization of supplemental disinfection. So those robots that I talked about, those hydrogen peroxide vapor machines, those UV disinfecting machines, if they're sitting in your environmental services department, they're not going to be optimally used. You need to strategically place them as close to the point of contact as where they're going to be needed. And then this is, it's not just a matter of do we or don't we need it. It's really how do we optimize their use is the point with that. And then this is followed by, of course, staff education, ongoing and initial, and the establishment, collection, and reporting of process and outcome measures, and figuring out which ones are the best indications for success. It's very much intended to be an application of this SEEPS model that we started talking about and the human factors engineering really in the healthcare environment. So it's working upstream in that work system before deploying new technology to the environment.
Really, really good stuff, Mark. I could tell you've been doing podcasting for a little while. Very smooth on the show today. I want to congratulate you for being an awesome guest. And I also want to give you an opportunity to tell everyone how they can listen to your podcast. Podcasting isn't one of those things where everybody's in competition with each other and they don't tell each other about the other podcast. It's really, meant to be a very open source platform for learning. So if you do want to share with the audience how to find the podcast and the other resources maybe on the blog, that would be great.
Yeah, absolutely. So if you go to pdihc.com and either /blog or scroll to the bottom of the homepage and find the blog, that's where all of our podcasts can be found. And they come out as we identify opportunities to talk with experts in the field, just like you guys.
Well, you're clearly an expert, and I appreciate you sharing your insights today. It really was a nice compliment to our interview with Daryl, and I'm glad that we brought you on to kind of take that next step in that conversation and get a little bit more into the details. And, it's funny, you basically outed me for not having good infection control practices. And I do say control, not prevention, because we weren't doing anything to clean those blood pressure cuffs. So I feel like you caught me red-handed today, but thank you so much for coming on.
Thank you so much. An ounce of prevention is worth a pound of controller.
Thank you, Mark.
Thank you, Larry. Thank you, Justin.
That was Marc-Oliver Wright, Clinical Science Liaison for the Central Region at PDI Healthcare, and also experienced podcaster Larry. And like so many people, I think Mark and the team, really, there's multiple podcasts over at PDI that really responded to the call to action for providing education, especially in this industry at a time of need when what might have been done in person in the past can't be done anymore. So podcasts like the one that Mark does and the one we do here are really, I think, so important because even then there's still very little in-person education happening today. And those conversations that happen on the side as a result of like listening to a presentation at a conference or anything like that, those are so critical to career development. And it's not just for IP professionals, but we talked about the human factors and we talked about, how to determine some of those things, sharing experience and talking through real life scenarios the way that Mark did on the podcast today to really paint the picture and help people conceptualize maybe situations that they've never run into before is so critical to that understanding. And I like this whole layered approach because I never thought about the blood pressure cuff, and I know he kind of made fun of that at the end of the interview, but really the emergency room, I never, from an environmental services standpoint, really considered how difficult it would be to just get that waiting room all to yourself to be able to perform effective cleaning, and what a challenge that must be.
Yeah, I think there's one thing we didn't talk about or focus on, and it goes to the concept of the Spaulding classification scheme, where Spaulding kind of matched the risk of a particular item or device or surface. He matched that with the level of disinfection or sterilization that was necessary to prevent disease transmission. So in the case of the blood pressure cuff, that would be what Spaulding classified as a non-critical device. And Mark talked a little bit about different types of disinfectants, for example, quaternary ammonium disinfectants, and that sometimes people can become confused of what type of disinfectant to use for what type of instrument. I think I want to underscore the point that if you refer to the Spaulding classification scheme, that can resolve a lot of the confusion and render a very straightforward approach and paradigm to using the right type of disinfectant for the right type of reusable medical instrument, device, or surface.
Really good points, Larry. And I know you and I have talked about the Spaulding classification system. That's an episode on its own. We should really dive into that and how it started, and it's been around for quite a long time. I know you've made some recommendations around that as well. So that would be we should find somebody to come and talk about that with us. But that's going to do it for this week's show. As a reminder, you can help support us by subscribing to Transmission Control on iTunes, Stitcher, or Google Podcasts, as well as Spotify or your favorite podcast application. You can also download our smartphone app for iPhone and Android. And we'd certainly appreciate a rating and a review because your feedback is important to the show. And on behalf of Larry and myself, thank you for listening to this week's episode of Transmission Control.